Good afternoon, everyone. My name is Steven Collens. I'm the CEO of Matter. Thank you for joining us for this discussion. For those of you who aren't intimately familiar with Matter, I'll give you the 60-second primer. We are a healthcare incubator and community nexus and corporate innovation accelerator. We work with about 200 healthcare startup companies, really helping them grow in normal times and navigate this situation today. We work with about 65 corporate partners, including a number of health systems to help them innovate better. And we are a nexus for the healthcare community, creating conversations about topics that are particularly interesting and relevant. And that brings us to today. We have what I think will be a fascinating discussion with physicians and a nurse from a number of Advocate Aurora Health facilities in Illinois, who are themselves really on the front lines of this pandemic. And people, we've all seen pictures of emergency rooms in New York or in Italy, and people I know personally have asked and are wondering, what is it really like inside of an emergency room during this pandemic? What is this experience been like, and what are the learnings that we could take away from it? So that's the conversation that we're going to have today. I'm going to briefly introduce each of our panelists. You'll see them come on the screen with me, and then we will start our conversation. You can use the chat feature of Zoom to ask any questions that you may have, and I will turn to those questions that you have and incorporate them into the conversation as we go, and we will finish promptly at 1 o'clock. So with that, I'd like to introduce Dr. Carrie Mendoza. She is a physician in the emergency department at Advocate Illinois Masonic, Advocate Trinity, and Advocate South Suburban. Carrie has a startup company herself and has been a longtime member of Matter and really helped put this discussion together. So thank you, Carrie, for joining us and for doing that. Dr. Ron Lawton is a physician is the director of emergency medicine for all of Advocate's Illinois hospitals. He's been practicing medicine for 29 years. Thank you, Ron, for joining us. Dr. Ross Kalman is a physician in the emergency department of Advocate Trinity Hospital on the south side of Chicago. Thank you, Ross, for being a part of this. And Ellen Bollino is the nursing director of both emergency and critical care services at Advocate Aurora South Suburban location. So thank you all again for joining us. Carrie, I will start with you and with a basic question of tell us what is a day in the life on the front lines of this pandemic for the last several weeks, and how does that differ from what the experience was in the ED prior to COVID-19?
Well, thanks, Steve, for putting this together. It's in some ways it is an interesting situation because it was something that in emergency medicine we're always prepared for, the unexpected, and that's just kind of what we always train for, because we really never know what's going to come through the door. And post 9/11. And various other public health emergencies, where always have been trained to sort of look out for those, zebras. So to some degree, it's part of our mindset. I think, the enormity of the problem and the fact that it just encompassed all of society, I think was, obviously a whole different magnitude than we're used to. And I think initially, it was definitely scary in terms of not clearly understanding the transmission rate and the degree to which we needed to protect ourselves on a shift with our protective gear. But, once we got that down, it's actually, I think, a very organized, calm environment for us. And I think that it really also highlighted how in emergency medicine, once we really know what we're dealing with, we all really get on the same page as a team and are quite organized with these type of situations. So I think that it really has shown a great faith in the way the hospital can get organized and the way our emergency teams can get organized very quickly.
And how, Ron, we've seen pictures and news reports from emergency rooms that are totally overwhelmed. Is that the case in any of the facilities that you are overseeing and practicing in? And if not, what does it look like from your perspective?
Yeah, fortunately, it's not. We did not get to that state of being overwhelmed at any of our sites. To go back to your question about, to Carrie about changes, what it's been like. I come from more of an administrative point of view. About 80% of my time is spent administrative and about 20% clinical. And so, in the beginning of this, it was really meetings from early morning to late evening. Initially, as Carrie mentioned, kind of figuring out what's the unknown here, what don't we know, figuring all that out, and then coming up with action plans and then executing on those plans. And so it's really been a transition during this time period, in a very short time period, from really being kind of overwhelmed with a bunch of unknown data and what's coming next, to getting more organizing and having structure and having the resources that we need. So it's really remarkable how much we've seen a change in the last just month and a half. And so I'm sorry, I deviated from your original question, Steve. What was your original question? I apologize.
No, that's that you actually answered it as to whether it's been totally overwhelming in the sense, in the same scope of what we saw from coming out of Italy, or in certain cases, New York. Maybe I'll tee off. Go ahead.
Yeah, I was going to say, no, I think one of the most remarkable things, one of the most surprising things out of this is really the responses from the communities, that we've been able to take the lockdown seriously and really flatten that curve. I mean, we were expecting to be overwhelmed, but we made all the plans to be overwhelmed. We built tents at every one of our emergency departments, ready for an onslaught of patients. Sorry, my light just went off. I've got a motion detector in this room. Anyway, so we were prepared to be overwhelmed, and just the great collaboration of the communities to do everything possible to prevent that surge of patients has been so impactful, that we're actually in a position where we haven't really needed to use our tents that much, and our volumes are surprisingly low in our emergency departments. When I say low, though, we're seeing less of the lower acuity patients, but we're still seeing very, very sick patients. So our volumes are down, but our acuity is certainly up. We're seeing the sick respiratory patients with COVID for sure.
Ross, from your point of view, physician on the front lines, how long? Ron had mentioned that it took a while to get things up to speed and put the systems in place. How long of a, what did that look like from your point of view, and how long of a process was it before you felt like the facility had the systems down to manage this situation?
Yeah, I mean, that's a great question. Thanks, Stephen, by the way, for having me on the panel. It's great to be here. My perspective is definitely on the front lines, and definitely, in the thick of it. I don't really do any administration. I've been working more shifts than ever. My perspective I can offer is at a community hospital on the south side is where I work. We have a sick, an underserved patient population who really at baseline does not have great access to primary care and services, let alone at a time such as in the pandemic. Things were a little chaotic at first, as I think they were around the country. We have been seeing rapid swings in volume, where there are some days where it's eerily quiet, but other days it's more kind of chaos, running from room to room, just with one ambulance bringing in another patient. What's making it so difficult, aside from having to work under all of the PPE, the gowns, the masks, the face shields, the food covers, you really don't know at this point who has COVID symptoms and who doesn't. There's so many bizarre, unusual presentations of the disease that we're seeing. On top of this, to get back to your question, when I say things were a little bit chaotic, I think everyone was just figuring out how is this going to work, and what sort of processes are in place. And I think initially, things were kind of changing on a day-by-day basis, where we were getting updates and different emails, different algorithms and different processes, how to handle different things. Even testing itself initially was a bit kind of all over the place, but we finally, after a couple of weeks, I think we've done a remarkable job smoothing things out and getting things to make a little bit more sense in terms of, how we're ordering testing, what are the algorithms for, delivering care and medications and, oxygen to different people. So things have definitely smoothed out a lot more over the past couple of weeks. And I think for a small community hospital, we've done a remarkable job of kind of coping and managing with this. So that's the perspective that I can offer.
Ellen, I'll ask for your point of view as well. And you also, you're overseeing the nursing in one of these tents and the emergency room and the ICU. You have an interesting perspective across both the emergency department and critical care. How do things look from your point of view?
We have a high rate of intubated patients in the critical care. These patients need to be proned. So that means flipping them over from their back to their abdomen, which takes 5 to 6 staff members to do. So identifying those patients each day, making sure we have enough ventilators, making sure that our staff are healthy. Every day we come in and we count our PPE. Do we have enough masks? Do we have enough gowns? Do we have enough ventilators? How many staff members do we have off on symptom watch? How many staff members do we have off that are positive? How many staff are we getting from the system and contract agencies? Really on the critical care side, it's been not as quiet as it's been on the ER side. So that's been a little bit of flip and what we usually see. And to Dr. Mendoza's point, to Carrie's point, the ER lives in the unexpected. We're used to it, we adapt to it. But the ICU team, this is a little bit different from that for them. They're used to already having those algorithms in place, and the care of these intubated COVID patients is challenging, and they're on the ventilators a long time. So it takes a toll.
And you mentioned PPE. There's been really an endless amount of news coverage of PPE. Have you experienced shortages in the South Suburban hospital, or I guess I'll open that to others afterwards if you've experienced shortages in any of the other locations as well?
We've experienced intermittent shortages. I mean, fortunately, our supply chain at Advocate Aurora is so robust that if we do start to run low on something, we're able to get that information out to the team members about conservation and reuse in enough time that we can get something delivered within 2 to 3 hours. But it's something that we keep a really close eye on, and the logistics really of healthcare supply is based on a predictability model, and the lack of predictability as it relates to the pandemic and the things that you wouldn't necessarily think about even beyond PPE. So in the ICU, they are using extension tubing so that the IV pumps can be outside the room to conserve PPE. So if the pump beeps or if they need to make an adjustment to the medication, they don't have to go into the room. And so then we started to run out of tubing, or when you intubate a patient, You check capnography. We're running on those, and so it's just every day it's a different supply that we're looking at how we can procure more. But again, I work for a very large organization, so identifying those hospitals that weren't maybe hit as hard as ours has been hit, we've been able to get supplies in, but something that we have to look at every day, 7 days a week, 24 hours a day.
And are there, in your ICU, presumably there are still non-COVID patients as well? What does the percentage look like now between COVID and non-COVID?
Oh, probably 25-75, with the 75 being COVID.
Wow.
Yeah.
Carrie, do you, are there, what is the percentage that you're seeing, similar question, but in the emergency department, split between COVID and non-COVID cases?
I think, early on, it obviously was, skewed, I would say, getting close to 80-90% COVID, with initially the mild cases, and then we moved into the, more severe cases, or moderate cases and severe cases. I think now we've actually seen a little bit of a shift back towards, some of the just regular emergency department issues. So I'd say we're trending back down, probably more of a 50-50, I think. But the overall, as Ron was saying, our volumes are down quite a bit for the overall amount of visitors that we see in the ER. But as well as what Ron was saying, is the COVID patients that are coming in now are much, much sicker. I would say, near 90% of them need to be admitted because they're hypoxic. So the sort of lower acuity patients seem to have either, I think, gotten the message that it's okay to stay home with self-care, or they might be accessing some of the, telehealth network that's been built up. And so I think that they're getting some of that medical decision-making through their primary care doctor via telehealth, which is something, that wasn't happening early on.
And have you, maybe Ron, I'll ask you this, have you, there was an article that I saw yesterday or today about the trajectory of COVID-19 and the effect on hypoxia, that there are a number of people who seem to have the condition. They are very hypoxic, but they don't know it, and they're just breathing a little bit more rapidly, but they don't display any of the other symptoms that somebody with severe hypoxia would normally present with. Have you seen that in your hospitals?
We have seen that. It's really a very interesting component to this, that a lot of the times the patients, they look really well and they don't necessarily feel that bad, but when you hook them up to a pulse oximeter, which measures their oxygen count, it's surprisingly low. And so what we've learned, and from following what's been seen in New York, is that the exertional oxygen count, what somebody's oxygen level is when they're walking briskly, for example, is one of the best determinants of whether they need to be in the hospital or not. And so we're incorporating that into our algorithms to decide, what kind of treatment options or placement options that we have for a patient, what their oxygen count is when they're walking.
Got it. Ross, what's the most surprising, assuming that's one surprising thing about the trajectory of COVID-19 patients, what's the most surprising thing that you've seen?
I think there's been so many surprising things. There's so much about this disease that we don't understand, that we don't know, and that's just reflected in how the guidelines and recommendations from our local governments and from our health organizations are changing all the time. I'd say the variation in all the different presentations, like, there's a textbook, what we thought was a textbook presentation of this disease with cough, fever, shortness of breath. And that's what worked, combined with a tribal history. Initially, that was what we were looking for. But as I'm seeing more patients, as we're all seeing more patients, there's some really unusual presentations that we're seeing. Vomiting and diarrhea, patients with altered mental status, which is generally not something you would think. Patients with chest pain and having, elevated cardiac enzymes, which we would often attribute it to something else, maybe not a viral illness. So we're really seeing a wide variety of presentations, which I think has been surprising for me. And as a consequence, we've just had to take almost automatic universal precautions, because you truly don't. There's no textbook case of what you might be seeing. So sometimes it's surprising after we admit a patient and you're like, oh, I thought it was one diagnosis, and it turns out that they were COVID positive. The disease just affects, or we're learning, affects so many organ systems and has so many varied presentations. I'd say the one other thing that has, surprised me a bit is that, to some extent, some younger patients, we're seeing a lot of young patients, not a lot, but a good percentage of young patients get sick. And it's really been a challenge to predict who is going to do well when they get the disease and who is not going to do well. And obviously, older patients with comorbidities, smoking, obesity is really being recognized as a big risk factor. But we just don't have the data or the knowledge or the understanding to predict who is going to do well and who's not going to do well from onset to presentation in the ED.
Ellen, you're seeing patients from the ED all the way through the ICU. And do you have a sense, or from a nursing perspective, do you have any sense that you have an ability to predict which patients are going to really deteriorate or decompensate compared to others?
To Ross's point, we've definitely seen younger. We weren't expecting the younger patients to get more sick, so we were bringing them into the hospital on the lower acuity units, not the ICU, thinking that maybe a couple days of oxygen, and then in 2 to 3 days they're progressing to ventilators. So it is that there doesn't seem to be a lot of rhyme or reason. Of course, those elderly patients that we're talking about that are always challenging to treat are still challenging to treat. But I think that initially, when the information was first coming out from the health departments and from the CDC, we weren't expecting to see young people without risk factors. And I mean, we can't answer that, why some of them are getting so much sicker than others. But yeah, we are seeing people as young in their 20s and 30s on ventilators.
And seemingly with no rhyme or reason to it.
Correct.
Are there other, open it to anyone, are there other viruses or illnesses that you have seen in your careers that have the same sort of variety of presentations and unpredictability of the course of their disease? Is it a function of the fact that this is such a new illness that's just not well understood yet, or is this one really particularly varied in how patients are presenting?
Hi, this is Ron. I can try to answer that. So I've been practicing, as you mentioned, for about 29 years, and I've never experienced anything like this. And I hope that I don't do it again. It's a unique illness that I think it's a once in a career event. We're hoping for us to deal with an illness like this in a pandemic situation. Certainly, viruses have many different ways of presenting. They can present with respiratory symptoms versus GI symptoms. But I think the range that Ross, mentioned, along with the different levels of acuity that Ellen mentioned, from, being asymptomatic to being, intubated in the intensive care unit, I have not ever seen anything like this before.
I think another one of the challenges is when we prepare from an emergency preparedness perspective, our plans have always really relied heavily on the CDC and the health departments to help us manage. And they quickly became overwhelmed, and we had to manage on our own and figure it out on our own. And I think that we've done an excellent job of that, and we've learned and adapted quickly. But that's the things that are put in place in planning really didn't work for these symptoms and this virus.
Yeah, so talk a little bit about staffing, and maybe Ellen, I'll start with you since you just touched on that. Are you pulling nurses from other specialties and other parts of the hospital to take shifts in either the ED or, I don't know if it's possible, but in the ICU to help out? How are you managing staffing?
We are pulling nurses from other places. So in the very beginning, we identified nurses who may be working in non-emergency department settings, but maybe have emergency experience. And so we identified those pretty early on, and we did get that help in the ED pretty quickly. The ICU has been a little more challenging. So I think that again, one of the benefits of the emergency department staff is they're adaptable. We're used to taking care of patients across the age spectrum, from babies to elderly, and from someone, who might have a broken ankle to someone who's having a heart attack. So we're used to that kind of range of age and symptomology, whereas the nurses in other areas are not. And so finding the nurses to work in the ICU has been pretty challenging. We've taken nurses from the procedural areas so that we're not doing as many elective procedures. So like the GI lab, the cath lab, surgery, those folks aren't as needed as much. And so we developed some training, and we've pulled them to work in these departments, and it has increased the productivity of our nurses to a certain degree, but it also increases their stress level in terms of making sure that the staff that are there have everything they need and have the knowledge and the skill to be able to take care of the patients. Fortunately, at South Sub, from the ED side, we have been able to get those nurses back. So we took a look in the last year at any nurse who had transferred out of the emergency department into a different setting, and we were able to pull those back. I haven't had the same benefit in the ICU side, so it's been a little bit more challenging. And then most of those procedural nurses are used to working during the day, whereas a hospital is a 24/7 operation. And so we've taken some of our regular day shift staff and flipped it to nights, because most of our help is on the day shift. And, I would say 75% of those nurses that have been redeployed have accepted it, the challenge with open arms, and the other 25%, it's really been a challenge. They're really scared to work with the COVID patients, and it's been a challenge.
How are you, Carrie, talking about being scared to work with COVID patients? How do you, what do you look like when you're working with a COVID patients? Are you wearing sort of a full suit? Are you wearing a mask? And how does that, what does it look like to be Dr. Mendoza on a day in the ER that's full of COVID-19 patients?
Well, I don't look like how I look now. So yeah, early on, as we were talking about, it was, I think, we were trying to be, the detectives based on symptoms. There's a respiratory patient in, room 10. And so that sounds like it might be COVID. So let's put all our stuff on. But we quickly realized within a couple shifts that there were unusual presentations, for example, like Ross was saying, like with GI symptoms, or maybe an altered mental status, or again, we haven't touched on yet, patients coming from the nursing homes or assisted living. So we quickly evolved into just basically at the beginning of a shift, putting all our protective gear on. And so it just is simple as, coming in the hospital, coming into the emergency department, and we have an area by the charge nurse where we have all our PPE supplies. So our N95, our face shield, gowns, gloves, And we just have that for our whole entire shift, because every patient is just pretty much presumed to have COVID. And we, have come up with a system to try and limit our times going into the room, whether it's, talking to the patient, from the doorway, or, working with the nurses to kind of decide on what the plan is in terms of medications and therapeutics, so they can limit the times they have to go in the room. But we are all completely covered in our PPE, during the entire shift. And, some things like we used to do, maybe have, our water bottle at our workstation, during our shift, or a snack or something. None of that obviously is going on. So just the activity of, trying to drink some water, you sort of have to, go in a different area, take all your stuff off, just to drink some water, then get everything put back on, and of course in a safe, manner. So that aspect of our daily work is definitely different, a new dimension of just a sort of routine we have to be in.
Sounds like a giant headache to me, but yeah.
Stephen, on my last shift with Carrie, it took me about 5 minutes to recognize that it was her, because she is all covered with the PPE, with the goggles and the mask and the bonnet and the gown. You just, you don't. It's hard to know who's who when you're working until you hear their voice.
Yeah, I would just add to that. From underneath all of the PPE, it's just such a challenge. Changing kind of how we're used to practicing, and that we're used to examining people and being close to people, maybe holding a patient's hand, putting your stethoscope on his or her chest, examining someone's abdomen. And it's kind of all changed. You walk into a room and you're covered in PPE, which automatically creates a distance between you and the patient. Especially if it's a child, that can certainly be intimidating, watching this, zombie-like creature, come in covered in PPE. But just how we practice on day to day. Some physicians I've seen are examining and interviewing patients from the door. So things have completely changed in terms of our interactions with patients.
And Ross, are you changing? It sounds like you're not changing PPE between patients. So what are the considerations around that? And are the non-COVID patients who show up in the ER or who are, in the ICU, Ellen, are they segregated in some other part of the floor so that it's easy to maintain that separation? How does that work?
Initially, we attempted to segregate. Initially, we had one critical care unit and one non-critical care unit dedicated to COVID patients. And then we quickly got overwhelmed with COVID patients, and we were no longer able to do that. We do have one department within this hospital that we keep completely COVID-free, and we test every patient that goes to that unit to make sure that they don't have it, so that we have a place to put our COVID-negative, immunocompromised patients. And so other than that, the rest of them, it's been difficult. And in terms of the PPE, in the ICU, the nurses have a one N95 mask that they wear all day long on every patient, and they do change their, and the face shield that they use, they do change their gown and their gloves in between patients, but we don't have enough supply of masks and face shields to change for every patient. So those are going into all of the COVID rooms. And then as it comes to the emergency department, in the beginning, when we first started, we did attempt to use the different PPE for each patient, and then we weren't using PPE for the patients that we weren't suspecting COVID, and a large portion of our staff got sick really quickly, and we had to move to the wearing PPE in the emergency department 100% of the time. And from what I'm hearing from my peers, that's kind of the national norm. As the ED staff is really on the front line, and if we're having them donning and doffing that's when you're going to get your most likely contamination and exposure. And we need those healthcare workers to be healthy in order to handle the situation.
What percentage of, Ron, I'll ask you, what percentage of your physicians have come down with COVID-19 themselves?
We've been fortunate. Very few of our physicians have come down with COVID. We've had a number that required quarantine from exposures, but again, few of those actually had symptoms. Currently, out of all of our sites, I don't think we have a single physician who is out due to COVID illness from the emergency departments. We've had one or two along the way, but none currently are out.
Sounds like, Ellen, that isn't the same situation with the nursing staff.
No, I would say percentage-wise, probably 25% of my staff has had some degree of symptoms where they've gone out on quarantine, and maybe 5% have been positive. Fortunately, all the folks who've been positive have done well, and a lot of them have already come back. A lot of those exposures happened early on before we had the measures in place that we do now.
Are there changes, Carrie, to have there been changes to workflow and processes and sort of the delivery of healthcare in the emergency department in this scenario that you think will persist beyond this pandemic, and that because they are in fact good innovations in the management of patients and workflow?
Yeah, I think so. I think some of the things that have been positive have included, I alluded to before, that I think there's been a more robust response from primary care and the hospital system at large to sort of really look at, well, what's the role of telehealth in terms of perhaps helping to triage some of these patients away from the ER if they don't need to be, and sort of empowering the primary care physicians more to be able to connect with their patients to answer their questions, because part of our function in the healthcare system, before COVID, and it'll still be afterwards, is just we are the safety net of the system, and we're the place that's open 24/7, after the doctor's office is closed, or, if an urgent care isn't, sure what to do and needs to send a patient. So I think some of the changes we've seen with an advocate is to really amplify and get in place some of these telehealth processes for primary care. And I think that that's helped to decrease some of the unnecessary emergency department visits that we were definitely seeing early on. And I think it helps protect patients who, don't need to come to the ER for their non-COVID issues and can get their care and medical decision-making by their primary care physician. But before COVID, that type of system wasn't really in place. So I think that process has been great. And I know, part of that, a lot of that was able to happen because of, on the federal level, they loosened up telehealth restrictions, which I think, the physicians have wanted for so long. So I think that's a process that I've seen improved. And I think, as I was saying initially early on, I think, even though this is obviously difficult and people are very, the staff was obviously scared to get infected themselves. I think that now that we have the processes in place, people feel comfortable that they know they're wearing the proper PPE and they kind of know, these undifferentiated patients, how to handle things. I think it's been, a mental boost almost for emergency medicine to see that, hey, we can really tackle any problem and really get things in place and do a great job with our patients and kind of stick together, you know, as a staff. So I think that, you know, I hope that that sort of focus on emergency medicine and everything we're doing will sort of continue to in terms of future things that we want to work on.
Well, hopefully this is a once in a lifetime thing, or even longer than that. But do you think that the, you know, it sounds like over the last 6 weeks, Carrie, from what you were just saying, that the staff have gotten more comfortable, that the processes are in place. Do you think that that is institutionalized or can be institutionalized, so that if God forbid in 15 years we go through something like this again, that the hospitals would be able to spin up very quickly the right processes and the right workflow and the right equipment, so that there isn't that ramp up period and that learning curve that everyone went through simultaneously?
I mean, I do. I think it's been definitely a huge shift in terms of, you know, quickly doing things that I personally have felt, you know, were efficiencies and things that should have been done, you know, 5 years ago, and things, you know, when I trained and practiced in Colorado, for example, they had kind of been doing, you know, some of these things a long time ago. So I do feel that there's been a major shift, and I think it's really going to stick. And you know, I think Ron probably can speak more towards, again, and Ellen, some of these administrative changes, because they're really deeply involved in that as well. So I'm curious to hear what they might say.
Ron, do you have thoughts on that topic?
Yeah, I can add on. You know, memories sometimes can be a little short, and we went through this to a lesser degree with Ebola and made a lot of plans around Ebola, and you know, and having PPE, donning and doffing, et cetera. And you know, some of that stuck with us, and we were able to kind of dust off the manuals for COVID, but maybe not as much as it should have. And so we're asking the very question that you just asked: is how do we document this? How do we ensure that you know, all of the lessons learned, all of the work that we've gone through in the last few weeks isn't lost for the future, and so that we are prepared, you know, for the next pandemic, you know, if it happens. And so, you know, asking those questions, and then also the question that you also raised is, you know, what good has come out of this? You know, we never want to let a good crisis go to waste. And so we have seen a lot of wins come from this, and we want to, you know, take a look at those and see, you know, what can we keep, you know, what are the things that we were doing in the past that we found out we really don't need to do, and what are the things that we're doing new that really have a positive impact. And so we're asking, you know, we're fortunately at a time where the, you know, the curve has been flattened, and we can start to you know, look at those longer term questions, and so it certainly it's being worked on at this time at the system level.
Great. Ross, different question. How do you, my sense, and I'm not a physician, but my sense is that over the last 6 weeks or so, the treatment and diagnostic protocols have changed like every 5 minutes. How do you keep up with, you know, what the latest are and how you're supposed to be managing your patients on, you know, any particular day?
Yeah, I mean, that's a great question. It really does seem like a lot of treatments and recommendations are truly changing, because they are, from day to day, from week to week. We've seen all back and forth with different experimental therapies, different, you know, antibiotics that might have some anti-inflammatory or maybe some antiviral activity, you know, azithromycin, hydroxychloroquine, remdesivir. And the data on these is just not clear and equivocal at best. I'd say one other thing which has really taken a dramatic change in how we're thinking about it is ventilation. And initially in this crisis, there was an urge to identify and intubate, meaning, putting someone to sleep, putting breathing tube down, starting them on mechanical ventilation. There was initially really an urge to do that quickly and aggressively, and there was lots of conversations in the media about running out of ventilators and rationing. And that is one thing which I think has somewhat dramatically changed. And now we're learning, as countries which are ahead of us, South Korea, really Italy, is producing some really good data that maybe early ventilation is not the best thing. So we've tried, and now there's really an urge to do alternatives to ventilation, things such as non-mechanical ventilation, things such as BiPAP or CPAP, or just means of keeping people awake, not putting a breathing tube down. And this has been much more successful because we're learning that, once a patient does require intubation, his or her morbidity and mortality significantly increase. So anything we can do, even if it's to keep someone off of a ventilator for a couple of days, is dramatic and is really helpful. And then I guess the question is, how is all this information circulated? And there's really all different ways, I think, of kind of getting this information out there and disseminating it to different doctors and nurses and practitioners. And I think, not back in the day, but maybe a couple months ago, things would have to be circulated through primary literature and starting out in journals and kind of filtering their way down. And that process takes months to years to go through peer-reviewed journals. And now we really have a need for much more urgent information. So personally, there are some really good podcasts that I've been listening to that have expert, panel discussions, different social media posts. There's different, doctor websites where people are just sharing and communicating really well and effectively, which helps you keep pace much more quickly with things that are so rapidly changing.
And Stephen, this has been one of our greatest challenges is, as Ross said, information was changing daily, and even at one point I would say it was changing hourly. And so it has been a challenge to get the latest information out to all of the frontline staff. One thing that we did in Advocate Aurora is we set up a central website that has all of our documents around COVID, including treatment algorithms, how to deliver oxygen, what's the appropriate PPE, what are the testing standards, nursing information, how do you prone, instructions for that. Even for staff, how do you stay safe at home, and what do you do if you think you have symptoms? So all of that has been placed on a central website for us. In addition, we have daily emails that come out from various levels of leadership with the latest information. We've been having daily phone calls with leaders across the system to disseminate information. So it's been a great challenge to get the information out and getting it to the frontline staff. But we're using a number of different modalities to do it.
Got it. Let's talk about testing for a minute. Maybe Ellen, I'll start with you. It's another topic where there's been an enormous amount of news coverage. I saw that Advocate was the first system in the region, at least, to have drive-through testing, and then there haven't been a sort of a volume of tests that I think anyone would like. And there've been some questions about the accuracy of different tests. So wondering your experience with both diagnostic testing, and then I don't know if you have any experience yet with antibody testing, but would be curious there as well.
When we first started, the only testing we had available was through the health department. So in the beginning, that was taking 12 to maybe even 18 hours to even get an answer from the health department if the patient was a candidate for testing. So in the beginning, that was a challenge. Then about 10 days in, we obtained a test that could be done within 18 to 24 hours that we could do at one of our laboratories. And so then it was a 24-hour turnaround. And now we have a rapid test. And the rapid test, we get, at our site, we get 30 rapid tests a day. And so we still don't really have the capacity to test patients who are going to be likely discharged from the emergency department. We do have the testing if a physician is, to Carrie's point, if they're differentiating between a patient with a lot of risk factors whose symptoms are maybe mild, if they want to send that patient home or keep them, those patients are getting a rapid test. But largely our patients who are being discharged, we don't have the volume of tests to be able to do that. When we have a patient who is COVID negative and they're an inpatient, they have to be by themselves because the specificity of the testing isn't enough that a negative that we would feel comfortable putting them in with another patient who doesn't have COVID. So those patients all have to be in private rooms. And then if a patient are positive, they can be cohorted together in semi-private rooms. And so the nature of the testing and how quickly we can optimize our beds in-house so that we have capacity has really taken up majority of our testing. We are also testing patients who are getting surgical procedures and moms who are delivering babies. So we do have tests, but we don't have as much as I think that the physicians would like in terms of giving those patients with mild symptoms the answer as to if they're going to infect their family members or not, because of course that's a concern. So if I come into the emergency department and I have, say, mild symptoms, but I live at home with or care for an elderly family member, and I still go home not knowing for sure if I have the COVID or not, that's been a challenging message for our providers to communicate.
And just so I understand, you said the specificity of the rapid test is not sufficient, so that if somebody tests negative, you're not comfortable telling them or treating them as though they are not COVID-19 positive.
So if we're talking about patients that are coming into the hospital, a large percentage of our rooms at this hospital are semi-private, meaning you would have a roommate. So we don't feel comfortable putting two negative patients together based on the accuracy of the test.
So we have a few minutes left, and maybe Carrie, I'll start with you and just talk on a more personal level. How are you, how have you, well, we talked a little bit about, how at first it was quite scary to be sort of on the front lines of this. How are you maintaining your own sanity during this whole process? And also, how are you, what's your approach to your family? And are you engaging with them? Are you distancing from them? And how are you making decisions about how to protect both you and your family?
Yeah, I think it's been a process like everything we've talked about. Early on, it really was quite scary because it was all evolving so quickly, and you weren't sure if, you touched something in the ER, if you were going to get it and then, bring it home. So I think there was a real high stress level at the beginning. And as we talked about too, processing all the information coming in about, what to do during shifts. You had to really, for me, I had to really, the night before, or even the morning before going in, just sort of make sure I was up to date on the emails, because there was just a lot of different information that directly impacted, what you were about to do. So I think there was a very high, stress level for myself. And then of course, with my family, I, have a husband and three boys, and, in my neighborhood where I live, it's like people, know I practice emergency medicine. So then you become sort of there's that person probably who's is touching all the COVID people. And so you sort of also, that felt, strange. But again, I think I feel, much more comfortable with the whole situation and really in the zone of really helping, doing, feeling like we're really contributing to helping, our community, and, feel comfortable with the processes. And in terms of my family, they feel more comfortable too, I think, as they've seen my anxiety level go down. But, I do bring an extra change of clothes to work. I change out of my scrubs and everything before I leave the hospital. You know, I make sure the car is clean. You know, right when I get home, I, you know, take a shower, and so limit my contact with my family till I'm completely, you know, feel as decontaminated enough as I can be. And so I think, you know, we're obviously it's changed some things, but I think we're in a much more comfortable, you know, zone with everything.
Ross, how are you keeping yourself healthy and well, and what's your approach to family?
Yeah, I mean, you know, emergency medicine by nature is stressful, and we always say controlled chaos, and this is no exception, you know, and this just presents new stressors. I would say there is a new emphasis, you know, that has kind of always been there, but in emergency medicine, we talk a lot about physician wellness and burnout. I think those are even more important now at times like this. You know, fortunately, I have a very supportive wife and a very supportive dog at home. And I really do worry about, fortunately, I don't have any, you know, elderly or sick people with whom I live, but it's always a concern, you know, am I going to get sick or contaminate my family? And as Carrie mentioned, you know, every time you go into a room, you have these concerns and worry about infecting yourself or bringing something home. But, you know, at home, I think there's a lot we can do to maximize our wellness. Things such as, you know, getting regular exercising, you know, getting good amounts of sleep, eating well, and just having outlets for stress, yoga, puzzles, or whatever. And I think this more than ever is increasingly important to prevent burnout, which is something we talk about a lot now, but, you know, has always been an issue in emergency medicine because we're, you know, very vulnerable to it. Yeah, so those things I just think are incredibly important. You know, to have a good family support structure and all the things I was just mentioning with wellness are really important.
Ron, how are you keeping yourself healthy in this environment?
You know, working hard to get enough sleep, making sure that I'm getting adequate sleep, you know, eating healthy, and Zoom yoga.
Zoom yoga. Ellen, I'll close it out with you. How are you approaching your family and keeping yourself healthy and well?
I similarly have decontamination procedures like Carrie before I go home to my family. And then I can't consume any of the COVID media after I leave here. You know, running a ER and ICU is a 24/7. So once I get home, I'm not really interested on kind of what's going on in the media. And then to Carrie's point, when it's that period of time before I come back to work, I consume as much of it as I can to get back up to speed. But having it's just everywhere, every radio station, every TV, it's at work 24/7. And so finding a break away from that to get back to some actual life activities, I think is a big piece of maintaining wellness.
Well, thank you all very much for joining us.
I'm sorry, can I make a last comment?
Absolutely.
Quickly. So, you know, first of all, thank you for having this event. You know, the panel here is really not describing, I think, the sensational doom and gloom situation that they're seeing on the TV. And that's not to minimize what's going on. You know, within the Advocate Aurora hospitals, we have over 600, nearly 700 patients currently admitted with COVID, and a good number of them on ventilators. And it's been very impactful for our day-to-day operations, which I think, you know, you've heard. But we may be downplaying a little bit here. And you know, I think that we have an overall maybe more positive perspective for a couple of reasons. You know, number one, you know, I think we had a little bit of a head start compared to New York. And so we were able to, you know, institute the lockdown, the social distancing and the lockdown. And that's had just a tremendous impact on how this has played out for us. We could be in a very different situation, you know, if people weren't adhering to that. So it's been, you know, it's really been a win, you know, for the Chicago area and for our community that people have adhered to that. I think the other thing is just, you know, that Advocate Aurora has been very active in planning and you know, rolling out new processes and ideas around the COVID. So yeah, I think that all of those things have just given us a little more positive outlook than perhaps what has been projected on TV. But again, you know, it's not to minimize what's really happening out there and the impact that it's had on us. which are great. So that's all. Thank you.
Yeah, I appreciate that. And I'm very glad that we don't have the same level of doom and gloom as there have been in other parts of the world here in the Chicago area. Sounds like you all have your hands full, and really appreciate you taking the time out to do this with us and sharing your perspective, and wish you all the best as you continue to take care of patients on the front lines of this pandemic. So thank you very much to everyone for joining us, and enjoy your afternoon.
Thank you.